Good morning, everybody. Welcome to Surgery Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for the presenter, please hold until the end of the talk. If you're attending virtually, you can enter your question into the Q&A section. A link to the evaluation will be passed out and also posted into the chat. If you are ABS certified and want NGHS to report your CME credits to ABS, please fill out the evaluation and give us permission to do that. And now it is my pleasure to introduce our speaker. Dr. John Mark Vermillion was born in Eastland, Texas, to a family of physicians. He graduated Phi Beta Kappa at Baylor University, where he was recognized as an outstanding pre-med student. He continued his academic excellence at Baylor College of Medicine, graduating with honors and AOA, Alpha Omega Alpha. Dr. Vermillion completed his general surgery residency at Scott & White Memorial Hospital, where he served as house staff president for 3 years. He attended his critical care fellowship at University of Maryland Shock Trauma, where he was named Outstanding Fellow. He later became trauma director at Scott & White before he was recruited to Montgomery to start the trauma program in 2005. He served on the American College of Surgeons Committee on Trauma for the last 18 years, on the board of directors for Alabama chapter of the ACS, and is a founding and current member of the Violence Prevention Committee for the Western Trauma Association. Beyond his professional achievements, Dr. Vermillion is a devoted husband to Misty, a first-grade teacher, a proud father of 5 children, ranging from a 28-year-old dentist to a high school sophomore. He's passionate about sports, thrives on competition, and enjoys traveling abroad, both for pleasure and surgical mission work. And now, Dr. Foxhall would like to say a few words before we get started.
It wasn't until last night that I realized I've known Dr. Vermillion now for 25 years. It's, I guess that's where this gray hair comes from. His uncle is who recruited me to Montgomery, and then whenever John Mark came, it was a breath of fresh air, and it's been a real pleasure and education. He has taught me more about the care of the trauma patient than anyone I've ever been around. And for that, I'm always grateful. And so I would like to welcome to the podium Dr. John Mark Vermillion, my friend.
I appreciate the opportunity to speak, and Dr. Foxhall is too kind. He's all professional here. We used to call him Fast Eddie in Montgomery. He got here and became all academic and fancy. He's not the one I used to know. So when I came to Montgomery, Dr. Foxhall was not one of my partners, but he's the one I called every time I got in trouble, because I was the young kind of hothead surgeon that was possibly doing some things I probably shouldn't even be doing. So there were some times I needed a second set of surgical hands that were calm and very helpful, and Ed's who I called. So I'll always be indebted to that to make me grow up as a surgeon, and maybe use a little bit more common sense on what I shouldn't do than necessarily what I should do. So I appreciate the opportunity to speak this morning. I've only got about 7 informational slides. I've got some stuff toward the end about our trauma system and our trauma numbers, just for informational purposes that we can go over. I'm going to try to wrap up around 7:45, so we have about 15 minutes for questions, if that works out well for y'all. If y'all don't ask questions to me, I've been given full authority to ask questions to y'all, so prepare some questions for me so I don't pimp y'all with questions. Just getting started, I have my talk entitled Disproving Darwin, Seldom Wrong, Never in Doubt. First of all, when Dr. Foxhall asked me to come, I asked him what the topic was, and he said, well, just tell your story. So that's about as broad as you can have. So for the first day, I was cursing myself for saying yes, because where do I go with this? But then the more I thought about it, you know, the thing going through medical training, especially surgical training, there's a pretty clear roadmap. I mean, there's nothing easy about it. Anybody that tells you there's anything that's easy about it 30 years ago when I was doing it, 70 years ago when Ed was doing it, just joking, or today. It's just, there's nothing easy about it. It's a hard road, and it needs to be a hard road. But the thing that I kind of wanted to talk today about is once you're done with training, the roadmap is no longer there. When you're in training, you know who you have to beat or who you have to outperform to get to the next level, and so on and so forth. You know who your friends are, you know who your enemies are, you know the major milestones you have to encounter and succeed in. After you're finished, all of those lines gray. Your friends one day may not be your friends the next day. Your partners are not always your advocates. The people that you employ are not always acting on your behalf. The metrics that hospital administration uses change year to year to fit their narrative, which is nothing on them. It's just a different agenda than doctors have. So it's a much more gray scale of career once you get done. And it's a very frustrating, it can be a very frustrating thing for a young surgeon because you expect you do this, you get this, you do this, you get this. And it's not that clear black and white once you get out. So that's kind of my main point I want to bring across today when I'm telling these stories. And when you get to these frustrating times in your career, it can be very isolating where you think this is just happening to you. And, you know, if I would just move and take a different job, it's going to be better there. And it's not. It's different. The first job I was in, I realized it wasn't my best setting, so I ended up taking another job, and the fact that my current job was not my first job is probably the only reason I'm still there 21 years later, just because I kind of realized that myself going through. So that's kind of the main thing I want to talk about today, and I've got a lot of stories to go along with that. So to my title, I'm a trauma surgeon. I have no problems with Charles Darwin's theory on survival of the fittest, but I feel like has been my career goal to disprove him, because as trauma surgeons, we keep alive the people who probably shouldn't stay alive because of the stupid decisions that they make. So I feel like our entire career is kind of spent even inadvertently disproving Darwin, because a lot of the people that we spend our time and effort on would typically be dead if it was left just to the theory of natural selection. And then kind of the co-title, Seldom Wrong, Never in Doubt. This was something that was ingrained in me early in my career, that failure to make a decision is always the wrong decision. And so, especially as surgeons and as leaders, and the leader of your trauma team, the leader of your OR team, the leader of your practice, you've got to make the decisions. You'll have to deal with the consequences. There'll be some good consequences, some bad consequences, even of the correct decisions. And you'll make some decisions right, you'll make some of them wrong. But you've got to be able to make the decision, you've got to be able to justify your decision, and you've got to be able to sell your decision to the people that are following your lead. So that's where the seldom wrong, never in doubt comes in. And probably more wrong than I choose to be, but you've got to still convince yourself that you need to make the decisions too. So here are my disclosures. I'm private practice, so we kind of get our hands in a little bit of everything. Unfortunately, the amount of money I'm paid by these three companies is much less than my expenses require, so I'm still working. And nothing today has anything to do with those commercial interests of mine. So starting off, these are the 5 topics I'm going to cover today. Do what you love and make it yours. Be available, affable, and able. Understand your worth. Adapt proactively, and model consistent excellence. We're going to get into these all more in depth as we go along. And if I don't get to all of them, that's fine too. So kind of my story. Where did it begin? So in doing what you love, so in my introduction, I was born to a family of physicians. So my grandfather was a surgeon who trained in the 50s, was a surgeon during the Korean War. My uncle was a surgeon. My other uncle is a family practice doctor. My father's an ER doctor. And the interesting thing is my grandfather, my uncle, and myself all trained at the same hospital, which is kind of unique. We're 3-generation surgical trained at the same hospital at Scott and White. So this was just the life I grew up with. It was not, we lived in a small town, and we were just normal people in the small town. We had a little bit more money than everybody else did, or not everybody else, and some people did, but there was not that much money because my grandfather would get paid in blueberry cobbler sometimes, or government cheese. I remember eating the big old blocks of cheese because that was how his patients sometimes paid him. But so the kind of the thing that caught me early on as a kid, by the time I was 14, all of the kind of my father's generation in my family had moved on. My uncles had moved away. My mom and dad got divorced, so my dad was gone. So my grandfather was still there, and he was the surgeon / OB / orthopedic doctor / general medicine doc managing diabetes in town. But he did a lot of surgeries because he was the only one that was a surgeon there. And he lost his first assistant after 3 p.m. So during the day, he had a circulator, a scrub, and a first assistant, but after 3 p.m., he didn't have a first assistant. So when I was in 8th grade, if I didn't have anything going on after school and he had a case, he would swing by my house and pick me up, and I would be a surgical first assistant. So I probably first assisted on 300 gallbladders before I was even accepted in a medical school, which is kind of an interesting scenario and, a strange start for somebody, and certainly not anything you would even have access to in today's medical legal world that we live in. But I mean, I got hooked at a young age. I mean, how do you pass that up? I was telling Ed this morning, I contemplated being a professional basketball player, but when I realized that my only talent was a three-point shot, I went back to becoming a surgeon because it just made a little bit more sense. So anyway, I kind of got hooked at an early age. I really realized the significance of the profession when my grandfather was out of town. I was a senior in high school. And this was before cell phones, really before even alphanumeric pagers. And my mom gets a call from one of my granddad's patients, and she says that I need to meet her at his clinic because she had an esophageal spasm and I needed to dilate her. And so my mom, I can't remember if I was at home or not, but my mom gets hold of me, whatever, and I called the lady back and I said, first of all, I'm 18. Second of all, I've never done this. And third of all, there's an ER that's open with an ER doc. And she said, well, you've never done it, but you've seen your grandfather do it about 4 or 5 times. I don't trust the ER because I've never met that doctor. And I know exactly where he keeps his the esophageal dilators in his office. And she said, and I know you have the key. And so I was like, okay. So, and I'm talking, I don't know if y'all have ever seen the old school esophageal dilators, but they were about this long. And you sprayed lidocaine in the back of somebody's throat and you blindly dilated their esophagus. I mean, about as barbaric as you would expect it to be. Not the fancy pneumatic dilators we do with endoscopy nowadays. And so I met her up there and I scared out of my mind and I dilated her esophagus. And I think that's when I realized what society expects and needs of a physician. And so that verified my decision to be a surgeon and reminded me again that I sucked at basketball. And so I started studying harder and continued on this path. So that's how I got started. Had a great college, med school, training program. Just so y'all know, you're going to look back in about 10 years and realize these are the best 5 years of your career. You don't realize it when you're going through it because it's hard, but it's so rewarding. And I had a great training program. It was very hard. I averaged 123 hours a week of work as a resident because it was before the 80-hour work week. We also could moonlight where I was training, so I did about 6 ER shifts a month because I had a family of my wife and 2 kids. And so I worked hard, but it was a very, very rewarding time. But I was recruited back to be a trauma surgeon at Scott and White, where I trained. And about 6 weeks into my career there, I was a brand new baby attending surgeon. The trauma director quit, or he resigned as being the trauma director. And the only other person that was credentialed to be a trauma director other than me was the program director, the vice chair of surgery, director of the surgical ICU. He had way too many things on his plate already. And so he comes to me and is like, hey, you're the new trauma director. So I'm 6 weeks out of fellowship and I'm suddenly named the trauma director of a level 1 center, which was a huge honor, but it was very eye-opening for me because I don't think I know I didn't have the maturity at that time to understand a lot of the sophistication of running a trauma program, running a hospital, the different interactions between not only doctors and other doctors, but doctors and nurses, doctors and administrators, different subspecialties. But it gave me a good exposure to that really quickly. Unfortunately, I was still a hot-headed surgeon with a pretty good resume. And so when the chairman of the department made the decision that we couldn't take call for multiple things at once as attendings, because this was in 2004, we would take call for, if you were a trauma surgeon, you would take call for trauma, the ICU, and acute care surgery at the same time, because we had a resident team for each one. So that wasn't overstretching and attending when you have a PGY5 on trauma, a PGY4 on acute care surgery, and a PGY3 that's taking all of your ICU calls. But our our chairman of surgery made the mandate that you couldn't share call anymore. So there were only 3 ICU doctors or surgeons, 4 trauma surgeons, and 5 general surgeons. And myself and my other partner, who was the vice chair of surgery, did all 3 of those. So I was on call every 3rd night for ICU, every 4th night for trauma, and every 5th night for general surgery, never overlapping. So I was taking call over 24 nights a month as a junior attending. And that didn't really sit well with me as the one who should have had some input into that decision. And I really shouldn't have, but in my mind I should have, because of the position I was in, even though I was way too young to really know what I was talking about. And that certainly was not very pleasant for my wife, who I had promised once residency was over with, my schedule would get a lot better, and it really was not better at all. So that kind of just opened my eyes to, I wasn't really looking for a job, but I wasn't really committed to staying there as well. And I got a cold call from a recruiter in Montgomery, Alabama, asking me to come to Montgomery and start a trauma program. So it was crazy to me that in 2005, one of the capital cities in the nation did not have any trauma surgeon, no trauma program, no surgical critical care teams, no organized anything. And so it was just a great professional opportunity. So I moved my family and my very supportive wife to Alabama. So that's kind of where my story began. Just to kind of put in perspective the negative things that will happen to y'all during your career that you have no idea or expectation. So here I am, I'm super pumped to be starting this trauma program. I got like 30% bump in salary because I went from academics to private practice. I'm thinking that life is good, I'm on top of the world. So I go to my office the first day and there's a certified letter on my desk. I'm like, that's interesting. I wasn't expecting this my first day. And it was a certified letter from every ENT doctor in town resigning their privileges from the hospital where I was recruited because they didn't want to have anything to do with trauma. So that was a good old kick in the shorts right upon, before I saw my first patient. That was my welcome to town. So that was followed about 6 months later. We had this very powerful pulmonology group in town, and there were only like 5 of them, but they pretty much ran the critical care for town, and they were offended that another critical care doc was there. Not that they had ever done any trauma. They hated trauma patients. They would transfer all of our trauma patients to Birmingham, but they didn't want me there. So they invited me to a lunch at their office, and I'm like, man, this is great. We're going to, mend some fences. We're going to build some relationships. Maybe we can have some good discussions. And after about 20 or 30 minutes, the head of their group stood up and personally invited me out of town in front of all of the colleagues because there was no place for me in the town. So that was my second one. Just so y'all know, there's only one of those guys that's still practicing, so I consider that I won that one, just saying, 20 years later. But they were also older, so they practiced because they retired. But anyway, I'm still standing. So it was just one of those things. Oh, and then finally the last 2 things. The 2 partners that were my bosses / trauma partners they started their own LLC to hire me. I was on a non-partnership track, and they did it because they thought trauma was going to go bankrupt in Montgomery. They didn't think it was going to be a moneymaker at all. And they actually took my call pay for the nights that I was on call as their, or as my penance for them joining along with me and supporting the trauma program. And at the time, that was very offensive to me. Now looking back, I kind of see where a senior partner got that because I was a young guy on a guaranteed salary from the hospital until my collections got up, and they were partners scraping by on the on what they could bill and collect. So, but at the time, as a 35-year-old hothead, that didn't go over really well. But still friends with both of the guys and still partners with one of them. It was just an interesting way to kind of step into the career. And then about a year later, our business manager ran our practice completely into bankruptcy, and we became hospital employees. So that's kind of the very negative start to a career that I felt was extremely promising, because I had checked all the boxes. I had done everything when I was in y'all's position. And then here I am 3 or 4 years out, and I feel like every time I try to get my head above water, I just get, pushed back down again. So I'd say that not to be positive, not to be negative, just to be real and let y'all know that when you get out, just expect some of these things to happen. And it's just a matter of figuring out how to get through it, because, and it's a natural part of any career, but especially part of our career. So getting beyond all my negativity to the next thing, kind of where we went. So my second topic was be available, affable, and able. And I was taught this, to be that. It's more important to be available than affable, but it's more important to be affable than able. And so in that order, and that's probably very true, because as surgeons, we have leeway to make bad decisions or make the wrong decisions. But if you're not present at the bedside making that decision is going to be questioned. If you're at the bedside making the decision as the one who should be making that decision, then you have very good support that was your decision to make, and you made the best decision you could at the time. So I truly believe that statement. So when I started in Montgomery, we had ER of the day, which is one of the craziest things I'd ever heard of. But there were 2 main hospitals in the day, and every morning on the radio, there was no iTunes yet, no streaming services. On the radio and on the AM TV stations, they announced which one was ER of the day. So it was ER of the day at Jackson or ER of the day at Montgomery. And the other ER was open, but all unassigned ambulance traffic was required to go to the hospital that was ER of the day. So we actually staffed our trauma surgeons, our operating room staff, everybody. We staffed them differently on our day for the ER than our non-day, just because our trauma volume was about 70% higher on our day of our ER of the day. Just a crazy situation. I actually became the medical director of Aerovac, which was the first helicopter company that came in. I became that because they wanted to land at my hospital our hospital every single day. And I said, if y'all land at our hospital every single day, my orthopedic doctors are going to leave, and my neurosurgeons are going to leave, and I've already lost my ENT docs, so we gotta try to salvage the best we can. And so I took a job that I really didn't like, just to try to salvage what we had. And that changed pretty soon. In 2008, the other hospital backed out of ER of the day, and our trauma volume jumped a ton. So the other things I have under the Aerovac are things that you don't know exactly what your career is going to turn into when you're being trained. And that's one of the beauties of general surgery training, because you have such a broad training that you really have the ability to do so many things with your career. And just because you do it the first 5 years of your career doesn't mean you're going to be doing it at my stage of your career. It doesn't mean you're going to be doing it at Ed's stage of his career. You're going to be flexible as you move on. So my very first Department of Surgery meeting, I'd been at the hospital for about 4 or 5 weeks, and I was a young guy. There was a little bit of hostility between my being recruited there, because a lot of the surgeons didn't want to have anything to do with trauma. And so I went to the first Department of Surgery meeting, and I was going to keep my head down and not say anything at all. And then probably about 30 minutes into the meeting, there becomes a screaming match about who had to do trachs, because the ENT doc's resigning, and there was going to be a citywide trach call schedule and all of this nonsense, and screaming, doctors at doctors, administration. And finally, I just stood up. I'm like, y'all, I'll do them all. I'm the trauma guy. I'm in-house. I'm going to do them in the ICU. I don't even have to post them for surgery. I was looking for RVUs. I was looking for business. I said, I'll do them all. And so I did. So the first 3 years I was in Montgomery, I did 562 trachs by myself, percutaneous, and I actually reported them at the Western Trauma Association because the numbers were absolutely crazy. And then since then, at times in my career and my partner's career, we've covered GI, urology, We cover plastics most of the time, ENT, breast, vascular, and even a couple nights cardiothoracic surgery. So those are just the things that we've kind of done over the 20 years I've been there. And not because we want to, but because we can. And, it provides a service to the hospital. And the more of these things that you're willing to step outside your comfort zone and be amenable to, the more indispensable you make yourself. And that's a very positive thing going through your career. Ask these guys that are here, whether you're trauma or breast or robotic, the more benefits you give to the more number of people, the more indispensable you become. Some of the details with our trauma system, the ER they ended in January of 2008, and our volume jumped 50% that first year. Alabama has an interesting trauma system. It's actually very well done, except it's not funded. But all trauma patients are routed through a state system. So if there's a car wreck a block south of my hospital, the paramedics call Birmingham, the TCC, which is the trauma communication system, and they route them to the closest hospital. So of course they're going to route them to us because we're right there. It's done because there's only 4 major trauma centers in the whole state, and there's a lot of rural areas in the state, so it was made to get the patients to the right hospital the quickest and avoid stopping at a hospital that couldn't take care of their needs and then delaying their trauma care. So that's kind of what started in about 2007 or 8 is when BRIM started across the state, and then we delayed adoption in our region until 2013 just because we were all in private practice, every single hospital, every single doctor in our region, and there's no funding for this, so it was politically a hard thing to get going for the non-trauma people. And the year that we started that, our trauma numbers increased another 35%. So here's the state broken up. There's my hospital, there's UAB, South Alabama is right there, and Huntsville is right there. So UAB is obviously the biggest level 1 trauma center with a ton of trauma surgeons, fellowship training program, all of that. We're actually the second busiest center in our state now, followed closely by Huntsville and South Alabama. And then all the other hospitals participate, but they aren't really their participation is mainly to stabilize and then send those patients to us. So I talked about making yourself indispensable. That's important, and it's also to understand your worth. And this isn't meant to be in a cocky way. We're no better than the administrators, we're no better than the nurses, we're no better than the janitors, but we are a commodity, and we bring stuff to the hospital that nobody else can bring. Now, they can replace me with another surgeon, but they're going to get another attitude with the other surgeon too. And seasoned administrators know that. So you've got to understand your worth, and you've got to stand up for the things that you need to stand up for. And that doesn't mean every fight, but we became hospital employees in 2007. We started that just like we did in private practice. It was collections minus expenses were the doc's salaries. Well, the problem with that is our general surgery practice, we billed about $18 million a year, and that means we collected probably about $8 million a year. And our expenses, we were very tight on our expenses when we were in private practice. When we became hospital employees, an $18 million budget is nothing for a hospital system that has a $700 to $800 million budget that they go through every year. So they did not pay attention to our billing and collections, not because there was any ill will, it's just because it was not a major budget line on their things to do. And they also didn't control our expenses because they were looking at hospital control expenses, not ours. So after a year of being a hospital employee, we were all working harder than we'd ever worked, and we were making about 50% what we had as private practice docs, just because neither one of us knew what we were doing. The hospital didn't know how to employ surgeons. We didn't know what to ask for when we were becoming that, because that's right when hospital employment became something. And then also, they didn't understand the global billing of trauma surgery. So, and hopefully all the residents, y'all are learning some of these things, but if you do a splenectomy on a patient and you do critical care on them for the next 30 days, the critical care is in the global period of the spleen, but if it's unrelated to the splenectomy, you can charge for both. Very common that's the way it's done across the nation. Well, our hospital billers didn't understand that. So if I did a splenectomy and then I did critical care on the patients for 30 days, they would bill for the splenectomy and none of the critical care for the next 30 days. Well, a splenectomy is 20.45 RVUs, and critical care every day is 4.5 RVUs. So if you have to choose, don't bill for the splenectomy and bill for the critical care, but you really should bill for both of them. So once I was kind of following those numbers, I had in one year, the hospital didn't bill for $720,000 of my charges. And I actually called for an audit per my contract, and the auditor, who was actually employed by the hospital system, said that, yeah, every single one was done correctly. So we had to go into some reimbursement type stuff through the hospital. And it was nothing, there was no ill will on their part. It was just, nobody understood the other side of this. And that's why it's important to collaborate, not only with your partners, but also with administration and other things going forward. That was followed by a Blue Cross Blue Shield audit that I had. And I was audited because my Blue Cross critical care billing was 20% more than my partners. I went through the audit. I paid the ACS to check everything for me. They agreed with all but 2 of my billings. I went to Blue Cross. They disagreed because it's their money. And at the end, I said, well, why did I get flagged? And they said, because your billing is 20% higher than your partner's. Well, I worked 33% more days than my partner. So as I was leaving, I'm like, y'all, thanks for this. This was it was a good educational thing for me. But my partner's one should be audited if you were really paying attention, because he's the one who's billing heavier than I am, because I'm working more days than he is. So anyway, I'm gonna have to speed up a little bit, y'all, sorry. It's the first time I've given this lecture. So I like to tell stories. So one of the things that my partner did, that I hired a partner, I hired one partner around when Ed was still there, and he didn't work out. And after we got rid of him, I hired another guy who was brand new, very intelligent, old school trauma surgeon. You want to strangle half the time because he's just that abrasive, but he's a fantastic person, a fantastic doctor. And really, after about a year in that more traditional private practice setting, he looks at me and he says, dude, we need to realize what the hospital really gets out of us. And it's not the RVUs we produce. It is the fact that we covered all of those specialties that I showed you all on the last slide. It's the fact that we're on call every night and we're within 15 minutes of the ER for every single trauma patient. And the amount of coverage that gives administration means something. And so we actually switched from an RVU model to an hourly based model for our compensation, which was good for, thanks for coming, Maurice. Y'all say hi to Maurice. He's our student. He shadowed me when he was just a child, and now he's a real deal. So I appreciate you coming, Maurice. Enjoy your day. Where was I? So we changed over to an hourly based compensation, which actually I thought the administration was going to hate, because they're like, well, now they're paying us as hourly employees. We're obviously a higher rate than I hope every other employee personally, but they actually loved the idea, because that set them a fixed cost for trauma. They knew every year this is what trauma was going to cost them, and any RVUs that I produced that I got bonused off of, they were making money off of, because it's money that they were able to bill for. So it was actually it was a great change that we made, and it had nothing to do with me. It was my partner, just saying, hey, we're being idiots about what we're really here for. And I put the whole thing not in the burger business, and I was going to have a clip, but you never know if the clips from movies play when you're giving a lecture. So if y'all have never watched the movie The Founder, I would highly recommend it. It's about Ray Kroc's story of revolutionizing the McDonald's brand. And the thing that he was doing, he had franchised that he was they were selling burgers, they were doing a ridiculous amount of gross profit, but their expenses were so high that their income margin was like 1.2%. So he was almost losing money, even though he was being extremely successful. And one of his advisors comes in and asks kind of about how the setup is, and they realize that when McDonald's went in, all of the land around that increased in value by like 20 times the amount of money it was worth before the McDonald's was there, just because of the amount of traffic that McDonald's brought. And so he basically tells Ray Kroc, he's like, you need to understand you're not in the burger business, you're in the real estate business. So that's kind of one thing that y'all need to think of as you're going through your career. And it's gonna be different for every person, but just don't hesitate to think outside the box. And when you're going through a lot of these negotiations and kind of career changes as you move on. Once we changed to our new compensation package, everybody was happy. We were crazy busy. I was averaging about 24,000 work RVUs a year. For those of you who are residents and don't know that exactly, the average work RVUs for a trauma surgeon nationwide in 2024, I think, was 8,200. And I know that trauma surgeons here are putting out a lot of RVUs, but that's a high number. But that's what trauma does. So I'm going to skip through a lot of this real quickly. Couple things. We had to get APP and use APP, so we have no residents. And so as our responsibilities increased, we had to figure out ways to broaden that. And you have to, that's a very difficult group to manage if you're not used to working with people who also have licenses and have the capabilities of billing, and especially under hospital administrations where they're expecting certain RVUs from them. I won't get into the details of that, but it's important to figure out ways to be able to spread yourself and spread your influence well and still give excellent patient care. And one of the other things, the two other things in this slide I want to really highly encourage is when you become, especially if you're a surgeon and a surgeon, you don't work alone. You're not in a dental office in complete control of your surroundings. You have to rely on the administrators, the hospital, the nursing leadership to give you good people to do your job. Because if you can be the best surgeon in the world, and if you've got an OR team that is no good at all, you're not going to have good outcomes. And so it's important to participate in the committee level meetings in the Department of Surgery and medical executive committees, just so you can make your voice be heard and also kind of know the direction that the hospital is going so you can protect yourself, your patients, and your practice. And then I would say to every single one of y'all, when y'all get out of here, you need to get an attorney, and not an attorney for medical malpractice. You need to have somebody that looks at every single document that you signed contractually that is looking at it on your behalf. We were recently sued, and the suit is still pending, so I shouldn't say anymore because I'm on social media and being recorded right now. But if you have an attorney, your needs and you will be covered because that's their job to do for you. If you rely on somebody else's attorney, they're going to be relying on those. They're going to be looking at those other people's self-interest. So one of the things that we started doing several years ago was TQIP. This was a big step for our hospital because it's a lot of money that is required to do TQIP, and trauma is unfunded in Alabama. So this is something that we started in, I think, 2021. We started submitting data, and it identified some really good things for us. Our ventilator-associated pneumonias were out of this world, but we were able to implement changes to get those down to a normal number or a better number. We had a ridiculous amount of catheter-associated urinary tract infections. We had tried to do some things with the hospital to try to minimize that. They wouldn't listen to us. And then when we got these numbers, and there was a study that was presented at Western Trauma Association the exact same year that this number came out for me, I was able to institute a gentamicin infusion protocol to for our longstanding Foley patients and the ones who have to have a Foley because they got brain injuries or, the long-term ICU patients. And since that time, we average about one catheter-associated UTI a year, and we run our average ICU census of trauma patients is about 14 patients. So we've reduced those numbers a lot. So doing the TQIP type stuff really helps you identify where you need to go with your trauma program. These are our most recent TQIP numbers, which is pretty incredible for a hospital that doesn't have the sophistication and the support, I would say, of this hospital. So for those of you who have never looked at a TQIP chart before, odds ratio is 1, so this is what the expectation would be. If you're below it, it's good. If you're above it, it's bad. That's simplified. A TQIP expert is here, and he can probably give you a whole lecture on that. But that's the bottom line of how to look at a TQIP number. And We do well with our TQIP, but it's taken years to do this because the first time we did TQIP, we had our penetrating brain injury was first percentile. So the absolute worst out of 100, we were the worst. And I said, hey, we may not be good every day, but we're not the worst. I've worked at much worse places. I've had much less aggressive neurosurgeons than we have right now. So we were the lowest you could be. So then we start querying and kind of looking into it, and we found out that our coders were coding a gunshot to the brain as a scalp laceration. So a gunshot to the brain has a predicted mortality of 80% plus. A scalp laceration has a predicted mortality of 0, so shocker that our numbers were absolutely horrible because we weren't coding it correctly. So it was really good to kind of dive down into that. The only two TQIP numbers that don't look good for us are these last two, and these are typically elderly patient ground level falls, and we don't include those in our registry patients. So any of those patients that happen to end up in our registry have other injuries as well, and so those are they're skewed because we don't have the denominator that we need to really know that for our institution. So just showing the growth over the years. In 2006 was the first year we had a registry. We had 448 registry patients. Last year we had 2,765 registry patients. We have 25% penetrating trauma, and we had 25% penetrating trauma when we had 448, and we have 25% penetrating trauma when we have, now this year we're gonna have over 3,000 trauma patients. We do our registry a little bit different than most trauma facilities because we're not trying to push our numbers because we're not looking at ACS level 1 or anything like that. So to get in our registry, you have to be a 911, a 922, or a state-activated trauma alert with an injury identified. And that's how you get into our registry. So we don't have hip fractures. We don't have some of the minor injuries in our registry just because we just hired our third registrar. And so there's no way we could keep up with that amount of data with the staffing that we have at our hospital. We have a ridiculous homicide rate in Montgomery. We saw 592 penetrating traumas in 2023, and we had 75 homicides with a rate of 38.3 per 100,000, which is higher than Baltimore and Chicago. We had ACS consults in 2024, and we're planning to be a level 1 trauma center next year. So one of the things, I started very negative. I've kind of ended probably too positive because this isn't about me. It isn't about, this excellent trauma center that I work in. Every day's a fight. I'm currently fighting 4 major fights with major different specialty groups, different things in our hospital, and every day is hard. And it's supposed to be hard. If it was easy, everybody would do it. But one of my favorite quotes, and I started putting this on all my trauma agendas now, so every trauma committee agenda, this quote's on the bottom of it, just to kind of remind people of why we need to do things, is this Ted Lasso quote: "The day we stop doing things the right way means we're one day closer to doing everything the wrong way." So, finishing up real quickly, so this is our trauma numbers with our region, and this is something the residents probably don't care about, but the trauma guys may. So here's our hospital right here, Baptist South. This is the first 6 months of 2025, so this is the most recent data we have. So we saw 1,484 trauma patients. Our entire region saw 2,095 trauma patients, and the region is the same as it was drawn earlier on that map that I showed y'all. So we touched 72% of the region trauma patients. We stayed red for only 45 hours, and so red means you can't take any ambulance traffic. So red basically shuts off your ER for trauma. Our problem in our city is if we're on red, there's nowhere else for those patients to go. So patients literally are in harm's way if we're on red. UAB has the same mentality up in Birmingham. So we try to do everything we can to stay off of red. The center that we used to share trauma with across our region was Southeast in Dothan, and it used to be about 1-to-1. We were very similar on our region numbers, and at this point, they're seeing less than 300 patients every 6 months, and we're seeing 1,500. So we've become the main trauma center for our area. And then finally, just trauma numbers in general. Here are our activations for 2025 through September. Obviously, we have a lot of blunt injuries, but the red line's a penetrating injury. So we typically see about 1.4 5 to 1.6 gunshot wounds a day is our average in our system, in our hospital. And here's our trend over the last 6 years. I omit 2021 data. We had a rogue QI or a rogue registrar that year, and she put in everything so she skewed the data so bad we couldn't recover from it. So we just don't put that in our slides. But you can see over the years our numbers are consistently going up month by month. And our busiest month ever was in October, where we had, I think, 288 trauma activations, which is the most we'd ever had at our center. So we're growing and we don't know how to keep up there, bottom line. And this is just concluding slide with the points again. And then my favorite quote, even more than Ted Lasso, is do not be overcome by evil, but overcome evil with good. So I hope I didn't go through that too quickly, and I have a tendency to talk too fast, and I have a combination of a Texas and Alabama accent, so that doesn't always mesh real well with talking quickly. So I hope that y'all could understand what I said. Questions? It's 7:46. We got 14 minutes.
Thank you, Dr. Vermillion. If anybody has a question, please raise your hand and I'll bring the microphone over to you. Any questions, comments? Oh, we have questions here.
I have a tendency to overshare when I'm being asked questions, just so y'all know. Be a little too transparent sometimes.
Thank you, Dr. Vermillion. Really appreciated the story, the history of how you got to where you're at. It seems that a lot of the successes or failures that you've had relate to not necessarily medical training, but your experience with dealing with people or dealing with systems, the leadership part. Where did you pick up some of the things that have made you successful, or do you think were gaps that residents should focus on?
I appreciate that question. So that's one of the things I actually meant to kind of start with that discussion, and I got off track with my topic. So, residency training teaches you, medical school teaches you how to be a doctor. Residency training teaches you how to be a surgeon. We were talking last night about the 10,000 hours to becoming excellent at something. So 10,000 hours to be a doctor, 10,000 hours to be a surgeon. And your first 2 years of practice, your first 3 years of practice, you still are learning your actual technical skills of surgery, because at that point you're doing it by yourself. You don't have somebody over your shoulder to call, or get their opinion on every single move that you make if you need it. But then after that, surgery's easy. You've done surgery for well over 10,000 hours. You're excellent at it, or you should be. And if you're not, you probably chose the wrong profession to start with. And then so much of your time and energy goes into management. And unfortunately, we're not trained in that at all, or at least I wasn't back in my day. So I'll have to say most of my learning was from trial and error, and a lot of it was from my errors. I did try to pay attention to other people's errors that were in leadership positions. So I remember a Department of Surgery meeting where I was vice chair, and the Department of Surgery chair made I can't remember what fight he decided to pick in the middle of a committee meeting. But I learned my lesson that day that you resolve the fight before you have the committee meeting, because that's not the place to have a fight. So I tried to pick up on other people just so it wasn't always because of my bad decisions. Another thing that I did, my wife's a CPA. Well, she's actually a first grade teacher now, but she trained as a CPA and just didn't like it when she got out. And I used to read the management books that she would read just because I never had it before. So the Malcolm Gladwell books, the other books that teach you management of people and just kind of how to temper your expectations and still push where you need to push. And so that was kind of the secondary place I got it. But unfortunately, probably most of it was just by mistakes I made as well. So hopefully I shared some of those with y'all today so y'all don't make them on your own.
Thank you very much. That was a wonderful talk. Looking at the trend in Montgomery, I don't think the population is getting larger, but it seems from your graphs and everything that the amount of penetrating trauma is actually going up. Is that what you're seeing? And is this just the way society is? Is there anything that we can do to prevent this?
Well, that's a loaded question. Next. I'm just joking. So the difference that we saw in Montgomery, and it's not unique to Montgomery, Birmingham had the same problem, Jackson, Mississippi has the same problem. So it's kind of, I think it's a unique to the South problem. With COVID, gunshot injuries went up exponentially for the 2 years of COVID. Most of the rest of the country back down and are actually at lower numbers today than they have been in probably a decade if you look at kind of national data for gunshots. And that's just not the case in a lot of the big cities in the South. So ours are, I wouldn't say they're continuing to climb. We just haven't seen the curve go back down like most of the country has. Most of our penetrating trauma is from Montgomery City. We do get a lot from the county. And as our center has grown, we're getting more penetrating injuries that get shipped in too. So our population isn't growing, but the population of our area isn't shrinking. And our population that we serve from a trauma side is almost 1.1 million people. So I think some of the transfers in have increased a little bit. But it's a problem. And that's why I'm on the Western Trauma Association Violence Prevention Committee. I mean, I think everybody knows it's a problem. The best way you have a good outcome from a trauma patient is for the trauma never to happen. Once somebody's had the trauma, they're probably never going to be the same. They're certainly not going to be better than they started out beforehand. So I think it's important, but there's no easy answer. So just keep doing our part.
Oh, we have. Okay.
Thanks for the talk. I'm Nate. I'm a PGY5 here. I wanted to ask you just a general question about surgery. In general, as we become more specialized, you talk about how you did all these different variety of, surgeries and so on. As we get more specialized and, a lot of us are doing fellowships now and not going to be doing the breadth of surgery that we were trained to do, what's your advice for us and how to maintain our skills as we get out of residency and we're not doing bowel resections every day and we're not doing lap choles every day, and then you come in on call and you're expected to do those things? What's your advice to us concerning that?
I think that's an excellent question, and I think it depends on where you end up practicing. If you're in a very well-established, very well backed up and supported medical community like y'all have here, you're probably not going to be asked to cover all of the stuff that I had it's a big city, but our medical staff seems to be shrinking. So I don't think the expectation will be quite what it is, but the acute care surgery call is true. You're being called in, and the gallbladders you do at 9 p.m. are not your 14-year-old girl blue hangers that take you 20 minutes. It's your absolute disaster and your 80-year-old man who's dying because his gallbladder's necrotic. So not only are you having to do things that you haven't done since your residency, but you're doing the worst cases when you're on call. So I think maintaining a place on call, as long as you think you might need to do that, is important, because if you haven't done it in 2 years and then you're asked to do that, you're going to be very uncomfortable. If you do it every couple of weeks or once a month, then you're going to be more comfortable with it, even though you're not as comfortable as you're going to be in your private practice, but you're going to be safe and comfortable. One of the other things that I've done, and in my introduction it said something about it, I do a surgical trip to Malawi once a year, and it is probably the most humbling thing that I do, because I go to Malawi and the ORs are nice. We have an anesthesiologist that goes, we have CRNAs that go, but we don't have any bipolar electrocautery. We do have a regular cautery machine. We have good lighting, but any of the advanced technology stuff that we have here, we don't have there. And I'm doing ENT cases on 6-year-old kids because there's no ENT there. Or I'm doing breast cancer, which I haven't done breast cancer since a resident because I hate breast cancer. Or you just do things because you are by far the most qualified person that patient's ever going to have access to. So going to a place where you can continue to use your skills in that situation is very good. And again, I'm on edge when I'm there because I do a lot of hernias, which I can do in my sleep because I've done so many open hernias. But doing the other things that you don't do once you get into your specialized practice, that's a good place to do it. Go into a place that's underserved, and I go to a Christian hospital that we support, but there's a lot of opportunities like that. Mercy Ships is one that you can do. There's a lot of those opportunities, and just making yourself be out of your comfort zone is a good thing. I appreciate the opportunity, y'all. Thank you.